December 25th, 2023. So it's Christmas Day. So it's a day to be with family, to appreciate being alive, breathing, and to try to be better next year and help more people out next year. The Christmas tree and the presents aren't the main focus. The main focus is to share with the beloved ones, and of course, it would be good to appreciate all we've had, and wherever you're at, it's always important to appreciate because you can always be worse. So we're breathing, it's a miracle. So that's it. Happy Christmas for everyone. And let's go on to do some questions. So let's go through these questions real quick. Which of the following, I'm going to try just to answer this the quickest I can, and you might see my test taken strategies or skills here. So which of the following is the most appropriate management to prevent urinary tract infection? So I haven't seen the question yet. I'm just seeing the options. Administer prophylactic trimethoprim sulfa. Yeah, that could be done depending if you're having recurrent infections. Check urinalysis and urine culture on third day of catheterization. No. Remove indwelling urinary catheter, that's usually the one. Replace urinary catheter with an antiseptic coated catheter. No, this is gonna be the best of these options. Let's see if this patient actually has the indication to remove it. So 77, heart failure, has the catheter. So the question is, can we take the catheter out? The patient has untreated urinary incontinence. They give us the medications he's taken, blood pressure, all the vital signs. And okay, so no. And he's urinary incontinent. So okay, they have been already monitoring his hourly urine output, and he's on intravenous diuretics. He has incontinence, so the best idea here would be probably to take out the urinary catheter, and the way you can monitor if this patient is urinating enough or not is putting him on a diaper and weighing the diaper, and that way you know how much he's urinating. That would be the best thing to do. That would be like the best evidence-based thing to do, and that's what I'm gonna basically mark. I'm expecting these people to know this. So okay, there it is. Early removal of indwelling urinary catheter should be considered whenever possible, with use of external catheters for patients with incontinence or decrease. So yeah, you can also do the condom catheter. Or increased urination when frequent toilet does not adequately address the issue. Let's go on to the next question. Or let's see why it wasn't the second most voted option. Replace the indwelling catheter. So option D, antimicrobial impregnated or antiseptic coated catheters may decrease the incidence of CAUTI, which is catheter associated UTI, with short-term let's see, or urinary catheter associated bloodstream infection with less than 7 days catheterization. Little information is available regarding benefits with long-term urinary catheters. Okay. So this next question, which of the following is the most appropriate management? So let's see the options again. Chest radiography, interferon gamma release assay, isoniazid, and no further treatment or management. Okay, so either do something, either not do anything, do something diagnostic, or do treatment. So let's see what it says here. 20-year-old follow-up consultation, 8 millimeter in duration tuberculin skin test during a pre-employment physical. She will work as a receptionist in a university internal medicine clinic. So your receptionist, so she's gonna be in the clinic, right? She's gonna be exposed to people, so she's not gonna be highly exposed, but it's going to be exposed, and it is positive. What you want to know is, if you pursue the tuberculin skin test, now you want to see if this patient has active or latent tuberculosis. and this is just another one. If you already did the tuberculin skin test, you shouldn't just play around with others that measure the same thing, so you do a chest radiography. And this one says no further testing or treatment. Okay, let's see why. Criteria for, oh, okay, so it was how much the induration was. So I thought 8 millimeters was above what we want, or above the threshold for normality, but actually no. Look at what it says here. It depends on the individual risk factors for TB. In persons with no known risk factors, a reaction of 50 millimeter or larger is positive. So what does this mean? It means that someone that is actually, well, yeah, in the background you can hear Kari doing things because we're in Christmas, or we're during Christmas. So I hope this doesn't alter the audio as much, but you can see that a person that has a normal immune system, it's gonna be 15 millimeter or greater, because the immune system is good enough. You can make a very strong immune reaction, as opposed to a person who is immunosuppressed. That's why HIV patients you'll have a cutoff which is way lower, right? If diagnostic testing for TB is performed, interferon gamma suggested rather than tuberculin skin test, and TST is acceptable if an interferon gamma is unavailable, too expensive, or burdensome. Okay, so let's see what are the cutoffs. 10 millimeter or greater, consider positive in recent arrivals, less than 5 years from high prevalence countries. If you inject drugs, residents or employees of high risk settings, hospitals, blah blah, homeless. Okay, and that's about it. I'm gonna leave it there because there's a lot of well, let's do the last one. Daily treatment with which of the following is the most appropriate additional management? So here we have tenofovir, which is an NRTI. Here you have tenofovir emtricitabine, which is the combination of those two. And here you have the combination of those two plus a integrase inhibitor, and here no treatment. So either do something or do nothing. That's the first thing we have to answer. So first thing we'll see is 31-year-old man seeking regarding pre-exposure prophylaxis for HIV, treated for rectal gonorrhea 3 weeks ago and syphilis 1 year ago. So it's a high-risk patient. He hasn't been sexually active since his gonorrhea. He has had receptive and insertive anal sex with multiple partners. Condom has been inconsistent. So he definitely needs treatment, pre-exposure prophylaxis. So his creatinine is normal. His hepatitis B surface antigen is negative. He is immune to hepatitis B, meaning that you can probably give him any of these things. So you'll probably, I think it's the combination. I think it's not only tenofovir. I think it's this one. So that's the one I marked. That's correct. Pre-exposure prophylaxis with tenofovir disoproxil fumarate and emtricitabine is recommended in all populations with an annual HIV incidence greater than 2%, including in men who have sex with men. Why wasn't it only tenofovir? So let's see why it wasn't option A. Tenofovir and emtricitabine based regimens have been shown to have higher efficacy than tenofovir alone for PrEP, which is pre-exposure prophylaxis. Neither tenofovir, or this is tenofovir alefamide and tenofovir blah blah, and the two disoproxil, those are the two presentations. Neither of those two tenofovirs in monotherapy is recommended for PrEP. So yeah, you have to give them both. And that's it for that question. Let's go on to the next one. We'll do a couple more. Which of the following is the most likely diagnosis? So here we have brucellosis, ehrlichiosis, heartland virus infection, and Rocky Mountain spotted fever. So I've never heard about heartland virus infection. If I've never heard of it, it probably is extremely rare. I won't mark that irrespective of anything I find here, basically. Ehrlichiosis and Rocky Mountain spotted fever are tick-related diseases. Brucellosis is more associated like to, what was it, cow milk or something like that. So, okay, let's see what we have here in the findings. 55-year-old in the ICU, requiring vasopressors. So he is pretty sick. Hospitalized 3 days ago with 3-day history of fever, headache, myalgia. Okay, fever, headache, myalgia. That triad. That's usually sounds like a little bit like Rocky Mountain. He owns a dairy farm, so a little bit of brucellosis here. Rural Arkansas and drinks on pasture. This is more of brucella. He is an active outdoorsman, so we still have the ticks in the mix. An admission to the hospital, he is febrile, pulse rate is high, no lymphadenopathy or skin lesions are noted. So empiric doxy was initiated on admission. If they started doxy, they were thinking probably of rickettsia, Rocky Mountain spotted fever, because that's the one you would give. It's not the medication you would give for brucella. So they were suspecting that, but let's see what happens. He takes no other medications. On physical in the ICU, he is still febrile, hypotensive, high tachycardic, and respiratory rate is high. Remainder of the physical exam is unchanged from admission. So here we have his comparative labs from day 1, which is admission, to day 3. So initially he does have leukopenia, and now he has more severe leukopenia. Okay, that can be a marker of sepsis. It could be a marker of bone marrow suppression because of the, of course, the severe infection. We'll see. Platelet count 110,000 to 65,000. So now he already had thrombocytopenia. Now it's even worse. AST was elevated, but it was like within 1 or 2 times normal. Now it's several times normal. So now we could say this is hepatocellular injury. Here it was just abnormal. This is more than 3 to 5 times upper limit normal. So now it's hepatocellular. So yeah, brucella affects. This sounds a lot like brucella. Everything has worsened. Doxy didn't work much, so everything is pointing me towards this. So that's the one. Everyone marked 62%, and actually it was heartland virus infection. Okay, that's the reason, because I had no idea about this heartland virus infection. So let's learn about it, and let's see what's the difference between that and brucellosis. Heartland virus presents after a tick bite with non-specific symptoms of fever, headache, myalgia, arthralgia, and malaise. So all the symptoms he has, which are non-specific. A lack of response to doxy distinguishes heartland from tick-borne. We already knew that, but we already knew that doxy didn't help the tick-borne diseases, but we had no idea about the brucella. So let's see why it wasn't brucella. Brucella is a zoonotic infection, but vaccination has virtually eliminated cattle as a reservoir for this infection in the United States. Internationally, ingestion of unpasteurized dairy products from sheep or goats or exposure to raw milk remain risk factors for brucellosis. A brucella infection responds to doxy. Okay, so that's another point I didn't know, which is that brucella does respond to doxycycline. So if I would have recalled that, I would have also ruled out brucella. So I would have ruled out this one, would have ruled this one wasn't high on my differential, would have definitely ruled out this one, and we would have ended up with like, what's this one? I'm not sure, and maybe would have marked it, but I didn't have enough knowledge to mark it. So what else does it say about this heartland virus? A tick-borne Banda virus, the Lone Star tick. This Lone Star tick is problematic tick, right? It's associated with that. It's also associated with this new allergy to meat, right? That it's associated to the tick. I think it's this tick that transmits it, but don't mark my words. Just tell me in the comment section below if I'm correct. And what else does it say? With human infections reported in Midwestern and southern United States. Ehrlichia capensis is transmitted by the same tick, therefore the regional distribution of the infection is similar and they are clinically indistinguishable. Okay, interesting. So Ehrlichia was very similar with common non-specific symptoms, Both typically present leukopenia, thrombocytopenia, okay. Elevated AST, ALT. Heartland virus does not respond to doxy, so that's the main thing. So yeah, I basically had no idea how to answer this question looking back on it, and that's why we're learning this thing. So it says Heartland virus doesn't respond to doxy. Treatment of the infection is supportive. Yeah, it's a virus, it's not going to respond, right, to antibiotics. And doxy is almost universal feature of for ehrlichiosis, anaplasmosis, spotted fever, Rocky Mountain spotted fever. Okay. Lack of improvement within 48 hours of doxy suggests alternative diagnosis. That's it. And let's do the last one. Which of the following is the most appropriate treatment? So we have continue cefepime, switch to cefazolin. Unless a patient is improving incredibly, I wouldn't switch anyone to cefazolin. Switch, same thing with cephalexin, and switch to piptazo. It's usually the thing to do if the patient is worsening, and continue cefepime if all is going well. So let's see what's going on. Sputum culture is now positive for MSSA, so it basically is telling us that you can de-escalate. So the answer isn't gonna be this one, because basically I don't even have to read this thing. It's just telling me this is MSSA. What are you gonna give? So you were given X drug. Now what are you gonna give? So let's see what was given initially. Pseudomonas or it doesn't say what the patient was given, but now we can say no, we're not gonna continue giving cefepime, because now we can tailor it. We're gonna give one of these two, and which one? The question, we're not going to give this one. The question is, which of these two attack MSSA? Cephalexin or cefazolin? I think it's more cephalexin, but it could be cefazolin. Let's see. It was cefazolin. Okay. Broad spectrum empiric antibiotic therapy should always be narrowed to a specific agent based on cultural results. Most patients with hospital-acquired pneumonia only require 7 days of treatment. Exceptions include patients who have bacteremia, metastatic infection, slow response to therapy, immunocompromised, or pyogenic complications. So let's see why it wasn't cephalexin, because it's a first generation. I think cefazolin is also a first generation, but let's see why not. C, option C. Cephalexin is an appropriate oral antibiotic for treating MSSA, hospital-acquired pneumonia. However, this patient does not meet criteria to switch from intravenous to oral antibiotic therapy at this time. Okay, that's the caveat. Cephalexin is just oral, while this other one, that cefazolin, is IV. Okay. So criteria includes stabilized vital signs, stable blood pressure, afebrile for 24 hours, resolving leukocytosis, and symptomatic improvement. So what we did have to give was cefazolin. And let's see. Yeah, when you have the hospital-acquired pneumonia with MSSA, you should give 7 days antibiotics. And empiric treatment should be used and then tailored based on the cultures. Okay, cefazolin has a narrower spectrum, and other treatment options are oxycodone, nafcillin. Okay, and that's about it for this question. Let's do a last one. Which of the following is the most appropriate treatment? So you have nitrofurantoin, trimethoprim sulfa, urine culture, cefpodoxime proxetil, and urine culture with ciprofloxacin. So in this case, this is a UTI based on the antibiotics. And let's see, we have to determine if it's complicated or uncomplicated. If it's uncomplicated UTI, you have the first options, A and B. If it's complicated, you probably would have to go to C and D, just based off on the antibiotics that are there. So 26-year-old woman evaluated acute cystitis of 2 days duration, 10 weeks pregnant. Okay, so this is also important. It's like, which ones can you give during pregnancy? So for example, that I know, you shouldn't give quinolones. You shouldn't give this one. This one is a trimethoprim sulfa. They affect the generation of folate. They affect basically protein synthesis. So probably you don't want to give this one or give this one. You could maybe give this one and this one. Nitrofurantoin is usually very localized to the bladder and urine, and active there, and not usually goes to the bloodstream. So I'm not quite sure in the context of pregnancy, but I vote for that one or cefpodoxime. So let's see. Medical history is significant for postcoital urinary tract infection. Last infection was 6 months ago. Only medication is a prenatal. Physical and rest is normal. pH results 7.1. Usual pH is going to be like 4.5 to 8. So 7.1 doesn't tell you much. Positive leukocyte esterase, yes, and blood and nitrites. So there are nitrates, so meaning there's gram negatives usually. And this just tells you there's inflammation, negative glucose, protein, and ketones. So it's either this one or this one. Cefpodoxime, cephalosporins are one of the ones that you can give, and it's a strong option. Urinary culture you probably wouldn't do in patients that are not pregnant, but in a pregnant patient you do want to make sure you eradicated the infection. So that's why you want to make sure you are very strict on the treatment, because you don't want this to affect the newborn. So I'd go with this option. Let's see if it's the right answer. Yes, it was the right answer. Cystitis in pregnant individuals is considered a complicated urinary tract infection and requires a urine culture and prompt treatment with antibiotics such as cefpodoxime, proxetil, cephalexin, cefdinir, and amoxicillin, clavulanate. Follow-up cultures after treatment are indicated in pregnant patients. So we just talked about that. So let's see why nitrofurantoin was not. Case control studies associate nitrofurantoin with birth defects. Okay, that's the end of the story. You can't give it. But it was not duplicated in a prospective study. Okay. A reasonable approach is to avoid nitrofurantoin in the first trimester if a safer antibiotic. Yeah, it makes sense. And that's about it for this session during Christmas, and I think I'll leave it here. And yeah, that's gonna be it. Well, this is an interesting one. Let's do one last one. Which of the following is the most likely cause of this patient's symptoms? So here you have avian influenza A, H7, and 9, chlamydia psittaci, Coxiella burnetii, hantavirus, and rhodococcus. Okay, pretty interesting. So let's see what's going on. Chest radiograph, bilateral interstitial infiltrates. So this one goes with this one, could go with this one. Not sure, don't think so, not sure. 59-year-old man, hospitalized, 5-day history of non-productive cough and fever. He recreationally breeds carrier pigeons. So that's usually with chlamydia, right? It's psittaci. He reports no travel outside the United States, takes no medications, physical, has fever, tachycardic, a limit of respiratory rate. Oxygen sats are a little bit low in room air. You should point towards 94, 95% or higher. Breath sounds decrease bilaterally. So I think this is going to be the answer. It's pointing us towards that. It's not saying that anyone else like is infected. It's not giving us any other information. It's going to be chlamydia. So that's it. Chlamydia psittaci presents indistinguishably from other causes of interstitial pneumonia, such as Chlamydophila pneumonia or Mycoplasma species. So a history of bird exposure is helpful in correctly identifying. Okay, let's just learn what Rhodococcus echi is. Rhodococcus echi is a gram-positive coccobacilli. I had no idea. Rhodococcus. I didn't. It seems like it's a coccus, but I didn't know it was gram-positive coccobacilli. And echi stands for horse. So yeah, it is an unusual cause of community-acquired pneumonia, occurring primarily in immunocompromised hosts and in patients with HIV. Okay, and that's about it. The end. Have a nice rest of your Christmas, and let's strive towards helping people out in 2024.